Now we go on to the next talk that is by Dr. Chee PHAIK. She's going to talk about putting these premium IOLs in challenging situations.
Thank you. So good afternoon, everyone. I thank Dr. Titiel for inviting me to participate in this very important course. So I'm going to talk about, the situation where inadvertently you have a complication, and what do we then do? Now, I'm going to start with a case which is a little controversial, right? It's a 64-year-old male who's a plano presbyope with cataract in both eyes, but worse in one than the other. And looking at how he runs his daily activities, he really wants to have a trifocal lens in that right eye. So let's have a look at the clinical examination. So the eye looks normal from topography, from of the OCT, of the optic nerve, of the macula, everything looks normal. But when you look at the cataract, what do we see? We see a polar bear there. And what's worse, all right, the polar bear has bitten through this posterior capsule. So am I going to be able to fulfill his wishes? I told him, well, we'll try our best. When we look at the anterior segment OCT, which Dr. Titiel, Dr. Namrata Sharma have actually taught us, actually it's very important to do this test, and you will see the type of polar cataract you have here in this right eye. All right, it's already ruptured, for sure. The posterior capsule is discontinuous there. So what lens am I going to offer him? So I'm just going to fast forward through this, because it's just how I do a polar cataract that's already pre-ruptured, putting some viscoelastic there under the anterior capsule, and then doing the phaco in my standard polar cataract technique. Okay, I'm going to just fast forward through this. So I just do a cross chop, and then towards the end, we have this epinuclear plate that's still intact over the polar opacity to protect the defect. Okay, so these are the last two fragments. I've done it without rotation, and here comes the epinuclear plate that has been protecting us from the vitreous phase. And dispersive viscoelastic goes into the bag before I remove the rest of the cortex. And still the anterior vitreous phase is not disrupted, so we're still being able to handle this case with wet aspiration of the cortex. And once we've done that, what lens shall we put in? So how many of you would go ahead with a trifocal lens? In this case, it's non-toric. How many would go ahead with that? One hand, two hands, a few hands. Okay, definitely not the majority. Okay,
But,
so...
Dr. Chee, the problem would be if this is the first case, and I put a trifocal lens in this, I never know what will happen to the other eye, which is also posterior polar.
Okay, exactly. I'm going to show you the other eye after this. Okay, this is the fun part. So I thought, okay, I'll try and grant you your wish. This is your dominant eye. You want this in, all right. I would have preferred this to be the non-dominant eye. But because, there's no loss of capsule, the support is still there, I can do it very simply. And so he had a good outcome for this eye. I told him, don't come back to me, but he returns 2 months later, and he says, now I want my left eye done, and I want the same lens. And this one is actually planned for a trifocal toric lens at 90 degrees, and if the capsule breaks, it's my fault. Okay? So we bring the patient to surgery again, and at the end, the capsule breaks, right? Because if one side it breaks, it's very highly likely that the other side would be quite similar. But fortunately, the direction in which it breaks is in my favor, okay? And I put this into the anterior chamber, as you can see. I'm rotating this toric lens to the axis that I intend at 90 degrees. And I'm just gently dropping this IOL, haptic by haptic, into the capsular bag. So this is a very safe way of implanting it exactly at the axis that you want it to be. All right, so this happens to be 90 degrees. and it was in my favor, and this eye also did very well. Let's have a look at this case now. This is a lawyer who wants to go to court the next day, and I had a small fragment that dropped, and you saw that rip in the posterior capsule. And my retina colleague was just about to walk out. I said, just wait, I have to put in this lens for him. So I said, I'm going to try something new. And you can see here I've written that 2010, that's how long ago it was, okay? And so I think this is probably one of the few cases that were being done on toric lenses that had a PCR like this with a drop fragment. I looked at the alignment, no, it wasn't good, so I redid it, but you can see I'm using lens grasping forceps that don't permanently mark, all right, on the optic. And once I am happy with the correct alignment, all right, which are not these marks here, I actually checked it with the toric ring, then I actually leave it there and optic capture it, okay? So even after optic capture, you can uncapture it, right, by holding it with the forceps and adjusting its position to a deeper plane, and then you can rotate and then lift it forward again. Okay, so in the case of anterior capsule rips, and we have premium lenses, all right? So this is a case here, and you can see that rip right across there. So what are we going to do? So this patient here, you can see, unfortunately, my toric axis is exactly there, but I felt that it was safe. I think this is controversial. I had adequate follow-up of this patient, and that lens, fortunately, has not rotated. I do think it does depend on your haptic design, but I have used the Alcon platform for many years in my practice, and I did not see any movement even with any capsule change. You want to comment on this, Dr. Titiel or Ramamurthy?
Oh, I think, these lenses are very stable, but now I think with the roughening up of the haptics with some of the other lenses that I showed, the stability is even better.
Yes, agree. I think the Technics platform, it's so difficult to even shift it when I want to move it 1 degree. Yeah, so anyway, this is how I got away with this eye, all right? It ripped right across there with a femtocapsulotomy, but it was fortunate this patient did well. Okay, now this is a little more challenging, and my fellow called me. She was doing this case, and she told me her rexus had run out. So here I am, the pupil is coming down now, the lens is not in. I'm doing a posterior capsule rexus because that's the only thing I think I can use to help to stabilize this lens. Okay? So soon we'll be able to see what's happening behind. She just described it to me. I believed her. So I've actually placed the lens again in the anterior chamber. And I'm going to rotate it to the axis. You can see here, 9 degrees. And I'm just going to put it behind. All right? Now where is the sulcus? Where is the bag? The pupil is so small. So at this stage, I said, okay, it's in a reasonable position. I'm going to do optic capture first. And then after this, I'm just going to check on it, all right? So actually, I should have put in iris hooks first because really I just believed her. And I said, I'm going to capture it here. But I need to be sure that the haptics of this lens are actually in whatever bag is left. So at this time here, I've actually expanded the pupil. And you can see that this part here, the capsule actually has run out. And I'm going to put the haptic in. And just here, there's really no capsule here. All right, the rexus has run out there. So once I put the haptic in, I've locked the optic into position. This lens is not going to go anywhere. So in this case, we managed to get away using the posterior capsule. So to fixate these lenses, you don't want the toric lens to shift, you don't want to shift out of the bag, right? You can really lock it in with the posterior capsule. So in the face of adversity, do not panic. The trifocal IOL must be centered perfectly, centered, preferably placed in the bag. but you can adjust for refractive error if it's placed anteriorly, in a case like in the posterior polar cataract, where there was a equatorial rib. IOLs with toric correction must be fixed in position and stable. So both anterior and posterior capsules can be used, and I showed you the case where I used the posterior capsule rexus. In that case, of course, the other way, if the posterior capsule gives way, you can anteriorize the optic and reverse the capture. But never place a single piece acrylic lens in the sulcus and it's not locked into place. All right? You may be able to use a premium IOL in the presence of a posterior capsule rupture and achieve optimal results. Thank you very much.
Can I ask a question, please?
Yeah,
Professor,
please.
that was a lovely surgery. I just wanted to know, what is the ring forceps that you are using to hold this thing? That looks very nice. I mean, can you give us a little more detail about it, please?
Thank you so much. It's called the Chee micrograsper IOL forceps. Initially, when I designed it, it was made under ASICO, which has now sold out to Katina Koza Katina. So you can get it there, and I have no financial interest. So it comes in a 23 or a 25 gauge.
Oh, 25.
Yes.
Thank you very much.
Thank you.
Dr. Chee, great presentation. I was glad to see that you do a reverse optic capture or optic capture of these premium intraocular lenses. Unfortunately, these lenses don't come in a three-piece platform. I have also done that in a few cases where you have had a PCR to stabilize the lenses, depending on where the capsular support is there. But the classical teaching is that, and when I've shown these videos, others have objected to it. Classical teaching is that, in a single piece, you don't have any part in the sulcus. And what is your observation on the postoperative follow-up, inflammation, glaucoma, etc.? I usually keep these patients on steroid drops or NSAIDs for a longer period of time. And it has worked out. What has been your experience?
I don't think there is really a problem. In fact, I didn't show one video where this was even earlier, like 2006, where I was putting in the Restore Plus 4. And I used a Royal injector, which is a single push, and it shot through the posterior capsule. And since the lens was already in the bag, all I did was I just used the viscoelastic cannula, went under one edge, and I just lifted it up and optic captured. And I followed that patient up for years, and she had no complications because the vitreous does not come forward, right? I don't go do a vitrectomy because it doesn't present. You've just ruptured the capsule, and you've not disrupted the vitreous phase because you've not aspirated. So I don't think there's a real problem with that. Even with the chafing, of the iris, I haven't seen that.
I think with this Alcon lenses, they are a little softer and the capture is easier there. So if you have a little rigid designs like a Technis or other lenses, very difficult to get capture. Both the posterior capture or reverse anterior capture, both are difficult in those lenses. So if you're lucky that you have these soft lenses, you can do all these procedures. But you rightly pointed out, never put these single-piece lenses on the sulcus. That is bulky and they can cause what Dr. Ramurthy talking about. These haptics can also create inflammation, which is not visible sometimes, but they are continuously rubbing against the uveal tissue and can cause uveitis and glaucoma, CME sometimes.
Yeah, so I've mainly used the Alcon lenses for this kind of a case because they're it's very easy to maneuver. They're not so thick. If you need to cut it out, also it's much easier than the Technis platform. And also because these lenses have a thinner profile. So I think if I anteriorize the optic, I really don't worry about having chafing and UGH syndrome. Whereas the Technis platform is thicker. So you may run into problems with a smaller eye.